Now, next step in management is to request some investigations. CBC may show mild normochromic normocytic anemia. This is anemia of chronic disease because of widespread inflammatory markers throughout the circulation, and mildly elevated platelets for the same reason. Raised ESR is a striking feature which is usually between 50 to 100 but can exceed 100. CRP will also be raised. The gold standard for diagnosis is superficial temporal artery biopsy. There is patchy or segmental inflammation, but longer portions can be involved. It has 100% specificity and it's better to perform because the course of treatment is long and complicated, so better to have a confirmed diagnosis in hand. Color duplex ultrasonography of temporal artery is an alternative to temporal artery biopsy. It has a higher level of specificity, but it lacks sensitivity. It's a non-invasive test and can be considered either as an alternative or complementary to temporal artery biopsy. Now, let's discuss the treatment of giant cell arteritis. The universally accepted treatment of giant cell arteritis is corticosteroids. They should be started as soon as possible, even before you get the results of biopsy. We divide the patients for treatment purpose into two categories: with visual symptoms and without visual symptoms. If patient has visual symptoms, then higher doses of steroids means 80 to 100 mg per day are recommended. Patients with acute visual changes should be admitted and IV methylprednisolone 1000 mg per day should be given, and it should be continued for first 3 days followed by oral steroids. If patient is without ophthalmic symptoms, then start with 40 to 60 mg per day. The patient should be well informed about the steroid side effects, and gastric and bone protection should be given. There is improvement of symptoms within days of starting treatment. So once the initial symptoms are settled, like after 4 to 6 weeks, the dose of steroids is tapered and reduced to minimum. The usual dose of treatment is 2 years, but in some patients it can be extended to 5 years, especially those who have off and on relapses. For those patients who can't tolerate steroids due to side effects or who have frequent relapses when giving steroids again and again seem inappropriate, immunosuppressant agents can be considered. Some of them are tocilizumab, cyclosporin, azathioprine, and methotrexate. As you all know by now, that giant cell arteritis is a potentially blinding and lethal disease, so a regular follow-up after a successful initial management is essential.